Hello and welcome. Today, bringing a special treat. One of our virus investigator is here with us. Please help me welcome Dr. Valerie Danesh.
Hi, thanks so much for having me.
Dr. Danesh, this is a pleasure. This is the first, I guess, we have interviewed quite a few of our investigators who have published ancillary studies from viral infection, respiratory illness, universal study, COVID-19 registry, or core studies as well. But we are very proud that as a part of our whole project that as a integrated hospital, like a site-specific data, utilizing it and publishing it as a first author. So congratulations for your recently published study.
Thank you so much.
All right. And for our viewers, the study is titled as a daily oxygenation support for COVID-19 hospitalized patient. And then this is a 12-month consecutive case series report from a large integrated health system. Dr. Danesh is a research scientist at Baylor Scott and White Health as well. So Dr. Danesh, if I have not done a justification to your introduction, by all means, introduce yourself and tell us about the summary of the study results or the inspiration to do this particular manuscript which you have published recently.
Thank you so much. From a clinical background and training perspective, I come from a background of adult ICU nursing, but I'm here today to talk about this paper on behalf of a diverse team that developed this paper, and wanted to say that our author group perspectives include epidemiology, practicing pulmonary and critical care physicians, health system executives, data analysts with expertise in data architecture and data extraction. So definitely a team writing and a team science approach for this.
Such a great leader, like giving due credit to the team members. So kudos.
Perfect. And we are very excited that to present this paper because it's really our first paper reporting on very large scale data from our 25 hospital system at Baylor Scott and White Health that are all on a shared EHR. And we thought this was an important first paper to develop because it contributes to epidemiologic insights into the day-by-day oxygen support methods that are required by patients hospitalized with COVID-19. We thought this was particularly important to get right and to really convey the granular kind of intra-hospital processes of care, because what we see in other large-scale reports are really masking all of the really mix of oxygenation methods and support and all of the clinical expertise and equipment that go into COVID-19 hospitalizations, because most reports are presenting data really at the hospitalization level for kind of the highest level of oxygen support needed. So for example, many papers just for like space constraints and focus of the analytic questions were able to understand like what percentage of their patients required high flow nasal cannula at any time during the hospitalization. But what this paper really conveys is a systems level lens on that epidemiology of demand. And so it's framed for clinicians and for health systems executives and administrators to be able to see from a very large health system. In this case, we're reporting more than 15,000 hospitalizations of adults over a 12-month consecutive period, and able to see that mix of oxygen supply or oxygen demands. So high flow nasal cannula, invasive mechanical ventilation, all of those components are conveyed in stacked bar charts by day. And then we also wanted to offer more epidemiologic insights into chronic critical illness. So we also provided data that extends past 6 days of hospitalization and extends all the way to patients that had hospitalizations of 7 weeks.
Fantastic. That is pretty comprehensive in that regard, and I don't think so. Not very many institutions could do it, and that is my. I've been impressed with the infrastructure you bring in or your institution. So tell us a little bit more. And this is a time to brag about your institution, where what infrastructure allowed you to actually contribute into a global registry and go into this level of data or this granularity of the data.
I am very nicely positioned in a system level department called the Center for Applied Health Research. And within that group, it's housed within the larger Baylor Scott and White Research Institute. And the expertise is really just astounding when it comes to data architecture and data manipulations and custom SQL code writing and the commitment to quality data control. So really the bulk and the headliner pieces of this data analysis are really hinging off of flowsheet data, which we all know in the informatics world can be a bear to not only extract, but really to do the manipulations because of the way that kind of log data is documented serially. In that really we just have start times of new equipment that overrides the discontinuation of the previous. So it's very dirty data in that sense, and getting it cleaned up and QA'd is no easy feat. And so that also explains why there isn't a lot of data out there at this granular level, because it takes a lot of data architecture expertise, a lot of data manipulation expertise. So bravo to E. Lau, to Vianne Bomar, to Anisha Shrisha, and to so many, to Elisa Priest. Thank you so much.
No, absolutely. And I think that is very important. You are a clinician, Dr. Danesh, and you are a clinical scientist. So give us some insight from your learning from this manuscript, looking at it from either from data perspective or from clinical care perspective. What are the lessons learned in either or especially in the pandemic? You know, you're presenting a 12-month series of early oxygenation granular data. What would you do differently as a nurse, as a clinician, as a physician, or as a PhD scientist if it comes to either taking care of the patients or collecting data or cleaning this data?
I think that merits its own standalone kind of investigation into lessons learned with the virus registry, and certainly so much to it. I think that a lot has been previously covered on just being connected with a team like at the virus aggregate level that's responsive to dynamic changes. Like, for example, we of course didn't have vaccination fields in the original case report form, and we're able to dynamically add those and morph them as needed. From a lessons learned perspective, I think at the base of it is the combination of project management skills and attentiveness to timelines and follow-ups, combined with an engaged and diverse team that all offer really important perspectives on everything from daily practice trends for quality data control to doing really advanced data logic checks to look for large-scale verifications.
No, I think that's very important, the things you have mentioned. Tell us your experience with working with, I believe this was your first time or working with Society of Clinical Medicine on this large scale study. What has been your experience? And then what would be your advice to the new or junior investigators who are in a similar position like you or I?
It's just fantastic to be involved with Society of Critical Care Medicine, both with the virus registry as well as with service on various national committees and efforts under that umbrella of SCCM. And I would combine that with the advice component to say that I think in research and in practice, we see a lot of things kind of statically and piecemeal because we're reading published papers and engaging in kind of post-publication dialogue in Twitter and via editorials. But getting involved in these kinds of large-scale multi-center trials for expertise sharing, as well as committee service with SCCM, really, it brings PubMed to life. And so it really is kind of a living, breathing PubMed of everything that we're interacting with for guiding practice and innovation. So just strongly encourage involvement, because PubMed coming to life, it really makes it that much more of a dynamic process and that much more exciting.
Absolutely. And then at the time of recording this video, SCCM just announced that the next conference is going to happen in San Francisco in 2023, and hope many of you who are watching this video today are planning to come there and meet us there, and then probably we'll have a couple of separate sessions on virus through Discovery Group as well. Dr. Danesh, share with us maybe a fun fact with you. It could be anything which you're comfortable sharing it, which you would like our audience to know you or remember by you, in addition to your excellent publication.
Sure. I'll actually do a shout out to one of our data analysts, Lau, and the way that we really were kind of pushing the limits and understanding how much REDCap as a data repository could hold. And one of the kind of memorable trivia type facts are that E decided to test the capacity of the free text fields, and he was able to import the entire The Raven. So it was very large. So that's my fun fact that we never would have guessed.
True. So yeah, exactly. And I love REDCap, but as we're realizing it, that REDCap is really good for certain tasks. If you have to have granular data, I don't think so. We can completely rely on a REDCap where there's every 5 minutes or every 1 minute of data from flow sheets or MAR or vitals will be coming in as well. So I think there are some efforts now to make sure that we are not confined by the limitations of REDCap, and we look for such important topic which requires granularity, greater granularity in the data. Any take-home message or summary from your publication today for our viewers, Dr. Danesh?
No, just thank you so much for the opportunity to kind of add some more detail to this paper, and we're just really proud to be able to share the epidemiology of demand for oxygenation specific to COVID-19 hospitalizations. So thank you so much.
You said it really, really well, Dr. Danesh. We really appreciate you being here today with us. We really appreciate you being the PI, principal investigator from your institution. And we are in awe of infrastructure, the leadership you have shown in your institution. And we really appreciate you leading this institution-specific manuscript, which is one of the first from the registry, means that each center was free to use their data in any capacity, any manner they want to. So we're extremely proud and excited this paper has been released, and then we look forward for future work from you with the same institution data or multi-institution data as well.
Thank you so much.
Absolutely. Viewers, please write in the comment section what you liked in this interview, and what questions you have for Dr. Danesh. We'll be happy to connect you with them as well. Otherwise, like and subscribe as usual, and we'll be happy to hear from you. Thank you so much again, Dr. Danesh.
Bye.